Hey guys, Stay Current Japan connects pediatric surgery in Japan and worldwide via the translation of online content.
Stay Current Japan は世界の小児外科コンテンツを日本の小児外科へ橋渡しし、また日本独自の小児外科技術や知識を世界に発信していく動画です。
I'm Shin Miyata, and here with me today is Dr. Maho Kurashima. We're from Cardinal Glennon Children's Hospital in St. Louis, United States.
本日の解説はアメリカの小児外科アテンディングの宮田真先生とインターナショナルフェローの井上真帆でお送りします。
In today's episode, we're going to talk about fundoplication without esophagocrural sutures, long-term follow-up from a randomized trial from Stay Current Pediatric Surgery podcast on November 18th, 2022.
本日は Stay Current Pediatric Surgery で2022年11月18日に公開された噴門形成術に関する RCT の学会発表とその質疑応答の様子を英語・日本語同時字幕でお送りします。リスニングのみ英語字幕を見ながら、または日本語字幕を読みながらなど、学習目的に応じてお楽しみください。エピソードに入る前にプレクイズを行います。聞き取れるかどうかチェックしてみてください。最後に今日のキーエクスプレッションを紹介し、解説を加えたいと思います。
What did the presenter say the potential weakness of this study was?
プレゼンターはこの研究の弱点は何だと言っていますか？
How did Dr. Todd Ponsky get criticized by his colleague about his fundoplication technique?
ドクター・トッド・ポンスキーは噴門形成のテクニックについて同僚からどのように批判されましたか？
According to Dr. Samir, why do some GI physicians have a hatred towards fundoplication?
サミアは消化器内科医が噴門形成術を嫌う理由は何だと述べていますか？これらの点に注意しながらプレゼンテーションと質疑応答を聞いてみましょう。
We have Dr. Kayla Briggs from Children's Mercy Hospital with her presentation, Fundoplication Without Esophageal Crural Sutures, the long-term follow-up from a randomized trial. And then following, Dr. Bethany Slater from the University of Chicago will start our discussion.
Thank you for allowing me to present our work. We have no disclosures. Our institution has performed a series of trials focusing on refining the fundoplication technique to minimize RAP transmigration and need for redo surgery. First was a randomized trial which demonstrated minimal esophageal mobilization resulted in fewer RAP transmigrations and need for repeat operation. Second was another RCT which evaluated the need for esophagocrural sutures with minimal esophageal mobilization, which showed that esophagocrural sutures were not needed if minimal esophageal mobilization was utilized. Most recently, a retrospective review demonstrated no difference in RAP transmigration between those who did and did not have posterior crural sutures. We sought to attain long-term follow-up from the children included in the second RCT that either got 4 esophagocrural sutures or no esophagocrural sutures. Children were included in the study if they were less than 7 years of age undergoing primary fundoplication. Retrospective chart review and a telephone follow-up to assess long-term symptom control was performed a minimum of 6.5 years post-operatively. 106 children participated in the original RCT, with 100 alive at late follow-up. 70 caregivers responded to a telephone follow-up call. 39 children had 4 EC sutures, while 31 children had no sutures placed. Follow-up was conducted at a median of 8.7 years postoperatively, and children were a median of 9.5 years of age at the time of follow-up. Of those available for telephone follow-up, there was no difference in sex, race, age at fundoplication, rate of G2 placement during fundoplication, or neurologic impairment at the time of operation. No child had RAP transmigration in either group. One child required a repeat operation, which was for RAP dehiscence. This was performed 140 days after the original operation. At telephone follow-up, there is no difference in current reflux symptoms, antacid use, persistent retching, need for GJ2 placement, or post-operative hospitalizations between groups. In conclusion, there was no difference in RAP transmigration, symptom control, or subsequent hospitalizations between those who did and did not have esophagocrural sutures placed during laparoscopic fundoplication with minimal esophageal mobilization at late follow-up. Thank you. I'd be happy to take any questions.
Well, first of all, go IPEG. And then second of all, thanks so much for having me. Dr. Briggs, that was a great presentation, and I really applaud you and all the co-authors for both a randomized control study as well as a long-term follow-up. I think that the technical aspects of a Nissen is really important, both for outcomes and for reoperation, et cetera. I was curious to know if you guys had done a sub-analysis for the patients with neurologic impairment in the two groups.
We did not specifically perform a subgroup analysis of those that had neurologic impairments.
Okay.
And I appreciate you being here today and being our commentator.
Great. In your institution, do you tend to get most of the patients back to your hospital if there are issues with recurrent symptoms, or do you tend to see people go into other hospitals, et cetera?
That is a really great question. And that was one thing that we definitely felt like was a potential weakness of this study. We have a huge catchment area, both in Kansas City, Missouri proper, Kansas City, Kansas, and all throughout the region. And, sometimes if people have those complications, they're not always super willing to come back for further care. We do find that kind of anecdotally, when anyone does have complications, our referring facilities are not necessarily afraid to contact us. The kind of bigger issue that we were wondering is that in our hospital, just as we were talking about, surgeons owning the common bile duct as opposed to GI, is that typically our GI colleagues here really dominate the post-operative care in these children with the fundoplications in terms of continuing medications, choosing when to discontinue those. And so that was really a question of ours, is should we be having more involvement with these children post-operatively to perhaps be a little bit more aggressive in getting off antacids if their symptoms are controlled instead of just going with the status quo. But that was definitely a concern of ours with as large as our catchment area and the presence of some other bigger children's hospitals that are around us that might have taken care of these children if there were any issues.
Great, thank you. My last question for you is, does everyone in your group now forego the extra sutures?
They do. And that Dr. Wendy Svetnoff posted kind of the most recent iteration of this, which was examining the posterior crural suture necessity, and recently published that data. So I anticipate that there will be a long-term follow-up kind of with this very minimal approach, minimal mobilization, no EC sutures, no PC sutures, here in the coming years.
Wonderful. Dr. Ponsky, are there other questions in the chat?
So not in the chat yet. So I want to invite people to start commenting about this, and I may have missed something. Also for the panelists, I don't know if Samir or anyone else here has a comment to make.
Yeah, I do actually. I'm glad that you brought that up. So I'm curious. I haven't done any crural stitches in probably a decade now. Mm-hmm. So out of curiosity, there's a few of us on this call here. Who actually still does those?
The posterior crural stitches?
Crural stitches?
When you say crural stitch, do you mean esophageal curl or a posterior?
The EC. I only do the PC if there's a hiatal hernia. If there's no hiatal hernia, mm-hmm. they're not getting one. And with all due respect to the senior colleagues, I do not skeletonize everything, because why break it up if it's already there?
So I'll answer your question. I got bashed by Tim Kaine because we asked, who still does it, and I was the only one that raised my hand. And Tim's like, Todd, hey, dummy. Look at the data. Stop being old school and doing what you were taught. So I am slowly trying to break my habit, and I do realize it makes no sense to do it anymore. Dad, you were going to say something?
Yeah, we'll get to fix these in years to come. You're providing material for the older surgeons to do. I love it. That's great.
Well, I mean, can I count it as a charitable contribution?
Yes, absolutely. Deduct it.
Want to keep your skills sharp, sir. That's what we want to do.
Too late for me.
We are here to aim to please you. That's what we're here for.
It's this will always be such a great area of controversy. So it looks like we have about a minute left. If anyone has other comments, if not,
pediatric surgeons are doing all your operations without sutures. You're fixing hernias. with purse strings internally. This is great security for us in the future.
There was one question in the chat about how many in the study had a hiatal hernia associated on imaging. Did you all have that?
That's a great question. So we specifically did not include children that had a concurrent hiatal hernia. And I actually did have a question for some of the senior authors too, in terms of the number of fundos that you guys do a year now, because we've definitely seen our volume drop off at Children's as medical management has gotten better.
That is a great question, and it is a very sore topic for me because I love this operation. And yes. Unfortunately, it is dwindling rapidly. And what I find in some of our GI folks, they have such a hatred towards this operation because they don't understand the floppy nature of the operation. They don't understand the minimal dissection, and they have this affinity for this GJ tube business that keeps on getting dislodged and blocked and needs multiple anesthetic exposures. And so, yeah, if you want to partner and write something up about that, I'm in.
That's an easy study to, I was just thinking, Samir, terrible minds think alike. I was just thinking the same thing. That's an easy study to do. It would be, but then remember I know the bell rang, I'm going. The pendulum swings, yeah. And especially on functional surgery. Anytime you're doing functional surgery, we can't figure out how to do it. And we do a lot, we do a little. I was doing 6 a day with Rothenberg when I trained, and now, right, Bethany? And now, I haven't done one in a super long time because we just don't do them anymore.
Yeah.
So final comments from anyone before we go to the next? Great job, Kayla. That was awesome. And great
Thank you for
discussion.
this opportunity.
それでは今日のキーエクスプレッションとプレクイズの答えを見ていきましょう。キーエクスプレッションの一つ目は Catchment Area です。該当箇所の字幕をもう一度流します。
We have a huge catchment area both in Kansas City, Missouri proper, Kansas City, Kansas, and all throughout the region.
キャッチメントエリアは一つの病院が対象としているエリア、つまりここでは一つの病院の医療圏ということでしょうか？
そういうことですね。病院や研修プログラムを紹介するときなど、地理的にどのくらいの範囲から患者が集まってくるかを説明するときに必ず使う表現です。北米ではハイボリュームセンターに症例が集約されている影響で数時間かけて救急車、車あるいはヘリコプター、飛行機で患者さんが運ばれてくるというのも稀ではありません。なので自然と病院が地理的にカバーしている範囲もよく話題になります。
なるほど。キーエクスプレッションの2つ目はアネクドータリーです。
We do find that kind of anecdotally when anyone does have complications, our referring facilities are not necessarily afraid to contact us.
データは出してないけれど、こういうことも見聞きしたみたいな表現ですよね。例文を引くと、Anecdotally, we heard that participants felt that survey was too long to complete. 参加者からはアンケートは長すぎると感じるという声も聞かれたのように、文頭に Anecdotally をつけてこういうエピソードもありましたよと本文に追加する例文が多い気がします。
そうですね。あまりサイエンティフィックなエビデンスはよくわからないけれども、聞いた話ではというふうに、正確なところはよくわかんないけど、よう知らんけどというときに、I don't really know the answer to that question などと言わずに、スタイリッシュに逃げるうまい表現です。あと、微妙にニュアンスは違いますが、似たような使い方で customarily という表現もありますね。
customarily 習慣的にはという意味ですよね。これはあんまり使ったことがありませんね。どういう場面で使うんですか？
What is the best timing to repair an umbilical hernia? って言われたときに、I don't know the most recent data, but we customarily repair those anytime after the age of 4. といった具合に、よくデータはわからないけども習慣的にはというときに使います。
なるほど。Catchment area Anecdotally を踏まえてクイズ1の答えを見ていきましょ
う。What did the presenter say the potential weakness of this study was?
プレゼンターはこの研究の弱点は何だと言っていますか？答えは医療圏が広大であるために合併症が起きた場合、必ずしも研究者の施設に患者が戻ってこず、合併症の把握に漏れがある可能性があるということですね。
プレゼンターの質問への回答が優れていますね。質問が研究の弱点についての指摘であるということを理解した上で、うまく用意してきた別の問題へと誘導しています。
なるほど。 キーエクスプレッションの3つ目は Old School です。
Look at the data. Stop like being old school and doing what you were taught.
これがクイズ2の答えになりますね。
How did Dr. Todd Ponsky get criticized by his colleague about his fundaplication technique?
ドクター・トッド・ポンスキーは噴門形成術のテクニックについて同僚からどのように批判されましたか？ Stop being old school の表現丸ごとで覚えたいですね。そう言われないように研鑽したいものです。
スクールを使った表現で他に School of Thought というものがあります。考え方の派閥的な意味合いです。例えば What do people do with the Kura when they do a Nissen? What do people do with the Kura when they do a Nissen? と言われたときに Well, there are two different schools of thought. Some people, some place EC stitches believing they will prevent rat migration and others don't.
クイズ3の答えを見てみましょう。
According to Dr. Samir, why do some GI physicians have a hatred towards funduplication?
サミアは消化器内科医が噴門形成術を嫌う理由は何だと述べていますか？
Because they don't understand the floppy nature of the operation. They don't understand the minimal dissection. And they have this affinity for this GJ tube business.
キーエクスプレッションの4つ目は Terrible minds think alike です。
Terrible minds think alike. I was just thinking the same thing.
直訳すると恐ろしい思想は似たように思考するですか？
そうですね。Great minds think alike. 賢い人は考え方も似ているというのはとてもよく使う表現です。それをもじった自虐的な、あるいは謙遜的な表現だと思います。例えば、脳葉形成が疑われるような虫垂炎を見たときに、Hey, what do you want to do with this patient with appendicitis? と言われたときに、I was going to get a CT and ask for IR for drainage if there's a big abscess. Cool, I was going to suggest the same. Great minds think alike.
なるほど。キーエクスプレッションの5つ目は The pendulum swing です。
The pendulum swings. The pendulum swings,
Yeah.
and especially on functional surgery. Anytime you're doing functional surgery, we can't figure out how to do it.
振り子の触れのようにある時はこの意見がいいという流れになったかと思えば、またある時は逆の意見がいいというふうに世論や流行が移り変わる様を表す表現です。私が日本で小児外科の研修中はしっかりと右脚と左脚の交点が見えるまで剥離して腹部食度を長く取るようにとミニマムダイセクションとおよそ真逆のやり方で指導を受けました。
まさに世の趨勢という振り子に翻弄される様子をうまく表せる表現ですね。いかがだったでしょうか？
かなり勉強になりました。
これからも Stay Current Japan では小児外科のグローバルスタンダードや最新のホットトピックを学びながら学会で使える英語表現なども紹介していこうと思います。
逆に日本にも世界に発信できる素晴らしい技術やトレーニング方法などがありながら英語の壁のために日本だけにとどまってしまっているものがたくさんあると思います。そういったコンテンツを英訳することで世界中の人に見てもらえるような活動もしていきたいですよね。
僕も全く同じことを考えてました。
Great minds think alike.
Thank you for watching this video. We hope you enjoyed this episode of Stay Current Japan. See you next time.